Oof.
How you doing?
I'm good.
Great job.
Thanks.
This is my first nighttime conference with glasses, so all I see is my reflection. Better?
That's good. I feel like I'm back in school and you're looking at me like this.
I am. Okay, so we have some questions, some comments, and also some personal experience. So this is it's kind of a long one, so I'm going to kind of put them up as I read them, and then you can let me know if we need to put them back up, because I can only put one up at a time. So I'm in the UK, and I was put on opioids and left on them for 13 years with ever-increasing dose. My life deteriorated horrifically. How do we ensure that the opioid crisis that you have in the US doesn't happen here? How do we encourage doctors to use only for acute pain or short spells and not for chronic pain? It's easier to prescribe. It's kind of a similar issue to here in the United States, as there's not much time together. But the opioids manipulated my brain into making me believe and argue that I needed them in order to survive.
It's hard. One, I hope you're doing well now. And there are, like I said in the presentation, there is, I don't remember the exact reference where it came from, but there is in the UK some discussion about what to do to limit the opioids. There is a lot of awareness in groups like the European Pain Federation and IASP for sure are very, very mindful of what's being said and what's being taught, what's being promoted at conferences about opioid prescription. So I'm confident to say that the whole world is paying attention to this. And honestly, I think some people are right to look at the US to say, we're not doing that. So hopefully they'll learn from our mistakes sooner than later. But I would say get a hold of like the European Pain Federation or the British Pain Society would probably have the most up-to-date information about what's happening there.
Awesome. Hi again. In my case, there was visible evidence of harm from the opioids. Some people don't have evidence of harm, so should they be allowed to continue? There's a second part. Hold on. I was told I couldn't because I became addicted, dependent because I was taking it for pain. I'm so sorry. I was told I couldn't become addicted or dependent because I was taking it for pain. It's on OxyContin and Oramorph and codeine, et cetera, et cetera. I can't imagine how the people in the US feel or cope and facing forced tapers.
Yeah, I just like, it sucks is my summary for that. My disclaimer of not being a pharmacist or a physician. So if I get this wrong and someone is listening that is that, I apologize. It's just not true that you can't get addicted to something just because you're taking it for pain, but different people have different responses to it. There's a term I heard from one of the addiction centers here in Chicago about accidental addicts, where you get really confused between different instructions from different providers and being in pain and then being fuzzy from the medication or all of the different side effects, and people can end up taking more than they're supposed to and it messes it up, or not taking enough and it messes it up. So the whole how to titrate the medication to an individual really needs to be individual and worked with providers that know how to do that. I think we know a lot more about how not to make mistakes than what to do when a mistake has been made and how to help someone out of it, which is sad. But there is something that I found out just this last week. Time is a little fuzzy these days, but I think it was this week that I had mentioned about the AMA keeping information on this, and apparently something is going to be moving forward where for specific patients in the US with specific physicians, they'll be able to get back on opioids for a short term with some better coverage while they try and find out what else can be used for them. So there's some movement towards a middle road with being able to cover the pain reasonably and responsibly while looking for another solution, instead of that just boom, you're off. Yeah, it's not good.
Okay. It's all hard, right? Okay, so now this one is, again, we have a character limit for how much can show up in each one. So this is, again, a multi-part one. How was the experience of being able to talk about this topic without the social pressure being in front of others? Did you feel that as enabling you to connect with the talk, or did you feel isolated, not having feedback? What was it like to have the freedom to cry? I noticed the colors of people of color in the presentation. Curious, was that a choice as an inclusivity of that population to this topic, or passive reminder this is a community which is impacted significantly with difficult access to healthcare, along with disregard by the system, thus inadequately served?
Can I go backwards? Is that the end of it? Thoughts on?
It looks like there's a part, like a second part, but let's just take the
okay. I'm gonna go backwards from this. I chose the pictures on purpose to have them not just be a bunch of white guys. So it is different on purpose, and there are certainly disparities in how people are have access to care and what kind of care they get when they do have access. And Deborah's talk on this was fabulous, of assumptions that are made based on someone's where they live or what color their skin is or anything. But I chose the pictures on purpose to just not be the same. Was it easier without? I think it's easier when there's people in front of me, because I can distract myself by looking at people instead of just staring at the little green dot in my words and being alone with my feelings. So no, that was hard. I think that's why it took me so many times to try and record it. Yeah.
Okay. Let me find the number 2. Okay, so here, thoughts on pharmacies gatekeeping gabapentin as a Schedule II drug when it is not, again, making access difficult.
Yeah, that stuff is weird. So many of the things, especially, and I only know to talk about the US, so many of the things about why a drug is a schedule whatever seems to be more political than rational at times. Some things that are perfectly safe and have been around forever technically could be over the counter, but then they put some medications that were over the counter back, and you need a prescription for them again, depending on who's seeing use and if they think people are selling them, using them to make something else, or taking them irresponsibly.
Okay. So sorry, I just need to figure out where we are. All of these are great comments and thoughts, but also it's very hard to keep track of them all. Okay. I'm not sure if this is a continuation. Okay. I would have argued black and blue that I was functioning perfectly on my high dose of opioids, but I wasn't. I could not see it through. So when people argue, how do we know their judgment is sound? I was fortunately persuaded that the opioids were harming me, but what happens if doctors can see harm but the patient cannot?
That's a really good question. I'm going to go from what patients have told me of like a couple that I was talking about in my presentation. They got it, that opioids sensitize and that it was not a good idea to have done years ago. And yet here they were. Their argument really wasn't so much, I want to stay on my opioids forever. It was, fabulous, take me off it, but you have nothing that's controlling my pain. So I think what needs to happen is a better education, a better discussion, maybe taking more time with people when you talk to them about why you're going to take them off of opioids and what possibilities are there, instead of what has been so harsh of you're off, or you get, I'm only going to refill this one more time. but then there's nothing to replace it. And I know that there are some people who have been taken off their opioids, have a really rough adjustment period, and do well. And those aren't who I'm talking about. So it's what if it's not working? So they, like the person that used to sail all the time, they know that opioids aren't good for them. Quite happy to never take them again, but they hurt too bad to do anything, so they're kind of stuck. So I think probably the best answer to that conversation is we need to talk to people better. And us as clinicians can be the people who do that. So maybe the doc said it, you know how that goes. Like I know, because I've worked with orthopedic patients, that they'll have a total knee replacement and they'll come in 2 years later and say, they told me I could never kneel again. I know that's not what the surgeon said. And I know they don't say that, but that's what the person heard. So sometimes maybe someone will come in and say, the doc told me this, and we could take the time to unpick it a little bit, or talk to the doctor and find out what they said, and maybe be that link for better communication and less stress. Yeah.
Okay. Awesome. Thank you. Okay. Here is another long one. I had a surgery, tonsillectomy, last year, and wasn't given anything afterwards for the pain, which was very high, other than Tylenol and ibuprofen, alternating specific doses of that. My doctor said the opioids wouldn't be any better for my pain than those. After 4 days of severe pain and the doctor taking all day to get back to me, he still refused to give me anything to help with the pain, and said I could get an anti-inflammatory shot at the hospital if I absolutely needed. When I went to the ER, they said I could up my ibuprofen and Tylenol, and that the shot wouldn't be any more beneficial. Here we go. Then just increasing those doses. I have had a very long conversation with my surgeon about my negative experience and not feeling validated, listened to, taken care of, or any other, or given any other ideas to help with the severe pain that lasted for 10 days. I tried meditation, movement, mindfulness, self-massage, which didn't even touch the pain, made it worse because it failed and didn't help. And I do not see the end of that. So.
Oh man, this is like leaving me hanging. Oh.
Wait, hold on. I might have it. Hold on.
It's showing.
Oh.
Is that it?
I think so.
Okay. He's confused, so he has more ideas on how to talk to the patient post. I would love to know your talk with him. I bet that was fabulous. See, we know this is where I get frustrated, because like my dentist did, that was really good. That hurt a lot. And Tylenol wouldn't have, I had to just know. I didn't even drive myself home. That's how bad it hurt. Sarah knows that scale level. I didn't try and do it myself. I can't even imagine that. So what she told me was great. And that's what the science says. So I don't know, I could look. I feel like that's all very old. The Brain Man video talks about that they're really good for 3 to 5 days, and then you taper off of them. I don't know why people have gotten so scared to use them short term, because that is what they're for. They've gotten kind of demonized, which is sad. And like saying we're never going to use opioids, we're going to get them off, it's just going to make people hurt more, which could sensitize them to pain, which is a really bad idea. So that doesn't make any sense at all. But I will, if you find me at the fire pit and tell me who you are, I will see what I can find.
Okay, and I think what might be our last question for this session, can you give an example of the patient deference charting versus typical regarding your last comment?
What did I say? Which last comment? The last comment in my presentation, or something I said here?
I think in the presentation.
That's awkward. Help me out, Sarah. What was I talking about?
So we just had some help from the backstage crew that says just from a long time ago.
Oh, when I was talking about, thank you, from a long time ago, the galaxy far, far away. Maybe what I was talking about was that some patients respond well and some don't to opioids. Like some will,
I
some.
hope I'm doing this from an earlier question.
Yeah. I don't know what it was.
Well, we have 2 minutes, and I think all of the questions have been answered.
Sorry.
Let me see here. Yeah, I think we got everything.
Because I don't think I think of the like so patient deference. If it could be that some people, the comment from the person who had been in pain for so long and opioids definitely made them worse, and that some people do get addicted to opioids even though they're taking them for pain, and some people don't, and some people will it's just like some people come off. It depends of orthos, as we don't have a way to predict how someone's going to respond to opioids. We don't have a way to predict how they're going to come off opioids. And I hope that answers your question, because I have no idea what I said earlier. That's normal. That's not even like because it's late.
And if you happen to be coming to backstage, you can definitely be part of the discussion. If not, you can head over to the fire pit in Gamer Drive, or we will see you tomorrow morning. What was that?
Find me tomorrow.
She'll be around tomorrow. And we will start off tomorrow morning bright and early, 4:30 a.m. Pacific time, or 6:30 a.m. Chicago time.
7:30 Eastern.
7:30 Eastern. Yeah, so another great day of things tomorrow. Those of you who have backstage passes, I'm going to open up the Zoom meeting in a minute, and I think you'll know in 2 minutes because there's a lag, and we will see you there. And if we don't see you there, we will see you in the morning.